Sir, now I prefer ARNI will be spoken by Dr. Arun Ranganathan sir, MBBS, MD Internal Medicine, DM Cardio, Senior Assistant Professor, Department of Cardiology, Government Stanley Medical College, Chennai. DM Cardiology, MD General Medicine, Postgraduate Students Teaching Facility in Stanley Medical College for more than 9 years, more than 10 national and international publications. Welcome you, sir.
Respected Chairperson, I would like to thank the GCDC for the wonderful opportunity. I would like to thank everyone here for the wonderful opportunity. Thank you, everyone. Today, we are going to discuss about some other interesting topic today. And a lot many speakers have talked about this. Professor Manoria sir have nicely discussed about ARNIs. But let us discuss whatever in this aspect we will know certain more new things. Diabetic heart failure, the role of ARNI. The most deadly disease truly is the failure of the heart. We know that heart failure patients across the globe will be like amounting to more than 70 million people. We know that whenever there is diabetes, there is a twofold increase of dating heart failure. Diabetes could cause heart failure by multi-mechanisms. One mechanism is like it could reduce the myocardial relaxation, and it can cause directly like cardiomyopathy, and it can precipitate acute coronary syndrome. And depending upon the etiology and the mechanisms, the precipitation of heart failure can be a preserved ejection fraction when only there is a relaxation of normality. When there is a cardiomyopathy or when this coronary artery disease stepping into a myocardial infarction, there the ejection fraction will fall down. Then there is a precipitation of heart failure with reduced ejection fraction. This has been nicely dealt by Dr. Hari Krishnan. We know that the focus here will be like the EF less than 40, which we term as a reduced ejection fraction, which is very important because these kind of patients have got the highest mortality, and the mid-range or the mildly reduced is somewhere between 41 to 49, and preserved ejection fraction is more than 50. So two important aspects we can discuss upon. One is like diabetes causing heart failure, wherein like I mentioned, it's a non-ischemic dilated cardiomyopathy. Whenever you see some kind of dilated cardiomyopathy, you do an angiogram, the coronaries seem normal, and we make a diagnosis of dilated cardiomyopathy. This is because of many mechanisms by which diabetes per se is causing this kind of dilated cardiomyopathy. And a more common aspect in this diabetes precipitating heart failure will be a preserved ejection fraction, possibly like causing a relaxation of normality. And the other thing which I told about can cause a myocardial infarction, wherein we get a ischemic dilated cardiomyopathy. In this group, the reduced ejection fraction is much more than the preserved ejection fraction. These are the mechanisms by means of which diabetes would cause a heart failure. And we know that when the glucose is not controlled, the activation of renin-angiotensin, abnormalities will be happening in the mitochondrial level, fibrosis, apoptosis, all these things, multi-mechanisms are operating, which will lead upon to left ventricular hypertrophy, diastolic dysfunction, systolic dysfunction, finally heart failure will be ensuing. So this is the pathophysiology here. We know that there are two important arms. One is like the activation of sympathetic nervous system, renin-angiotensin activation, all these things are there. So far, many mechanisms and the most commonly used drugs were like beta blockers, AC inhibitors, ARA, ARBs and MRAs. But when you move to the right side of the slide, we can see the beneficial system is also there. That is the natriuretic peptide system. When neprilysin is there, this neprilysin will cause degradation of these molecules. So the positive benefits of this beneficial molecules is not happening. So the ARNIs are playing a major role by inhibiting neprilysin. The enhanced good benefits of this natriuretic peptide system is obtained. So this has been nice to tell the quadruple therapy, as Dr. Professor Manoria has clearly explained. The four important pillars of heart failure are AC inhibitors, ARBs or ARNIs, beta blockers, SGLT2 inhibitors and MRAs. So our topic today is like ARNIs. Neprilysin, we know it is a neutral endopeptidase found on the surface of many cells and in the circulation, and they are involved in the metabolism of this natriuretic peptides. And this is mainly indicated in the treating heart failure with reduced ejection fraction, and it can be given in also heart failure preserved ejection fraction with a class 2B indication. Herein we can see the mechanisms of ARNI, the green one, wherein the positive effects of this natriuretic peptide, positive effects of this natriuretic peptides can be obtained in the form of like decreasing the sympathetic tone, decreasing cardiac fibrosis. Multiple positive beneficial effects can be obtained when neprilysin is inhibited, and all these positive benefits can be obtained. And we all know the red one, that is the classical renin-angiotensin axis inhibition by using AAC inhibitors or ARB. In this case, we are using valsartan, which is a ARB. And this is one more slide depicting taken from the McPorey Heart Failure Journal, which is clearly depicting the various possible good effects obtained by sacubitril, which inhibits the neprilysin, and valsartan, which is ARB. So the important landmark trials, Professor Manoria has clearly outlined till date the various trials. Just I would like to focus upon certain important trials alone. Paradigm HF trial, this one is one of the landmark trials which clearly tells that in those patients when the ejection fraction was less than 40%, there has been a 20% risk reduction for the primary morbidity and mortality. It means that it gives two important benefits. One is the mortality benefit, another is the hospitalization for heart failure. Both the benefits were obtained from this trial. And thus came the Paragon HF trial. Though this trial is said to be somewhat did not give a positive result, there are two important observations which we can make out. Even though it doesn't provide a cardiovascular mortality benefit, the hospitalization for heart failure is definitely reduced. And importantly, when a subgroup analysis of this Paragon HF trial was done, it clearly indicates that women are much benefited, and people who have got an intermediate ejection fraction, that is the range between the 41 to 49, those people are also getting benefited. And most importantly, the quality of life and the symptoms of heart failure will be reducing, so the patient will feel definitely better. The Prove HF trial is one of the most important landmark trials. Sarah was telling about the indication for ICD itself is getting reduced by using this molecule, and we can see the clinical benefit by means of two aspects. One is the NT-proBNP levels will start to fall down, and importantly, while we do an echocardiogram, we can nicely see the reduction in the LV end diastolic volume, and the various indices of the echocardiac parameters will definitely improve. This is the Pioneer HF study. This is one trial which has been done in the acute decompensated heart failure, and it doesn't mean it in the acute state it has to begin. After stabilization we can give this, and the NT-proBNP level decline, as we see for example when you see diabetes, we monitor the sugar levels, hemoglobin A1C. Similarly in heart failure, the values of NT-proB when it starts to decline is a clear-cut indication that you're really working good, your drugs are nicely acting. And these are the various indications like the guidelines. One is on the ESC, one from the AHA. And the important here is like the ARNIs are much more like from the AHA 2022, it is clearly indicating that ARNI is stopping above AC inhibitor or ARB for treatment of heart failure. It has got a class 1 indication in those patients who have got a heart failure with reduced ejection fraction. And for this preserved ejection fraction, and we know that it has got a class 2B indication. So this is the way we need to start. We need to check the renal parameter values, and we need to have a 36-hour time before AC inhibitors. If the patient is on AC inhibitor, we need to have a 36-hour waiting time for starting this molecule. These are the contraindications. And we need to check the blood pressure. It is one of the most important thing. That when the most of the time when the BP is very less, we do not have the liberty of starting this molecule. So these are the various things we need to keep in our mind before starting ARNIs. How the BP, so the BP should be better, so that when you start an ARNI, the BP will try to fall down. And these are the cautions. We need to monitor the potassium values, and also we need to understand about the various interactions, whether for example we are using MRAs, if you are using some other molecules like NSAIDs, these can also increase potassium. So we need to be cautious in these ways. So these are the various things we need to adopt. We have to start with the low dose, just step up every 2 weeks and try to achieve the target dose, and every time 3 months once at least we need to check the potassium and the creatinine values. So these are the various method of problem solving. If the patient has got a low blood pressure, doesn't have symptoms, just we need to reassure the patient. Cough could be some trouble as a AC inhibitor. And then renal failure and hyperkalemia, these require some kind of monitoring, and the potassium values need to be monitored. So the conclusion here is ARNI for is got a class 1 indication for ejection fraction of less than 40%. Whenever you get a heart failure with reduced ejection fraction, it has got a class 1 indication. For a preserved ejection fraction, we can try this molecule because it has got a class 2B indication. Even though there is no mortality benefit, definitely the hospitalization for heart failure will not be there, and also the quality of life will improve, and also the symptomatic benefit of the patient will be there. So we can start at the clinic level, and in the hospital level, after the acute decompensation state is getting stabilized, we can start the molecule therein itself as a de novo without starting any AC inhibitors or ARB. So sacubitril valsartan can improve the real outcomes because it can cause a reverse remodeling property, which is not like very much pronounced in many other drugs. So ARNI can be preferred in cases of heart failure. It should be preferred among the 4 important drugs. And these are the references. And our greatest glory is not in never falling, but in rising every time we fall. Thank you for the patient listening. Thank you, sir.
I think both the speakers has done a wonderful job, but it is very important to remember both drugs should be considered complementary to each other and not competitive. It is true that SGLT2 inhibitors can be initiated in any stage of heart failure because they do not affect the heart rate, the blood pressure, the potassium level in EGFR, unlike ARNI, which does affect blood pressure, EGFR and potassium. But both should not have a competitive, they should be complementary to each other depending on the subset of patient of heart failure. Sometimes you can initiate only SGLT2, sometimes both, sometimes all the 4 drugs. So all depends on the part, but we never try to compete with each other. Thank you very much for your kind attention.
Thank you, sir. Thank you.
Next, we have a live cardiac intervention demonstration which will be chaired by Dr. J.M. Ravichandran Edwin, sir. He is MD, DM, FACC, FESC, FSCAI, Professor and Head of Department of Cardiology, Tirunelveli. We have a TAVI